Okay, I want to welcome everyone to Grand Rounds. It is a super snowy and cold morning, so I hope a lot of you are online. And I really want to say a welcome to the primary care peeps who I know are in clinic and are probably seeing this streaming. So I'm Dr. Betsy Trowbridge, and I am the Vice Chair for the Department of Medicine. And I am really very honored and excited to present our two Grand Round speakers today and their topic. And that is Dr. Brian Arndt, who is a professor in the Department of Family Medicine and Community Health, and Dr. Mark Micek, who is an associate clinical professor in the Department of Medicine and the Division of General Internal Medicine. And they're talking about a really incredibly important and hot topic, which is the primary care workload beast. How can we rein in the electronic medical record workload? I'm going to do just a little bit of introduction about each of these physicians, and then I'm really going to talk about their collaborative research efforts. So Dr. Mark Micek did his medical degree at Northwestern University. He then went to the other UW, University of Washington in Seattle, where he did his residency in the primary care track in Boise and was followed by a chief residency at the Boise VA. He did a general internal medicine fellowship where he received his master's of public health at the University of Washington, Seattle, and did some postdoctoral work in HIV research. The very first part of Dr. Micek's research career was around HIV, where he studied HIV in Mozambique. In this last piece of time as a general internist has been researching telemedicine, the EMR, wellness, and burnout. A couple awards I would like to note is he is a member of AOA. He's a fellow in the American College of Physicians. He received the 2019 General Internal Medicine Excellence in Performance in a Time of Crisis Award, and really a coveted Department of Medicine Award in 2021, which was the Department of Medicine Page Grossman Professionalism Award. And in case you didn't know, he speaks Portuguese. Dr. Brian Arndt from the Department of Family Medicine and Community Health did his medical degree here at the University of Wisconsin School of Medicine and Public Health, which was followed by a family medicine residency here also at the School of Medicine and Public Health. He's done specific leadership training in the Physician Leadership Development Program here at the University of Wisconsin. And he just got promoted to professor in 2022. Congratulations for that. And he has received incredibly number of coveted awards, and I'm just going to mention three that I think are really important. In 2022, he received the Mike McKinney Community Volunteer Award from the United Way of Dane County. In 2020, he received the Aspirational Leader Award from our Gold Humanism Honor Society, and he has been a Madison Magazine Family Medicine top doc. So together, Dr. Micek and Dr. Arndt are part of a research collaborative that studies the electronic medical record, burnout, workload, and wellness. They have been working together since 2018. Dr. Micek wanted me to just say that they have an incredible research team. I know that to be true. They are both part of PATH, which is Primary Care Academics Transforming Medicine. They have been funded for their work through the American Medical Association. They have had 4 grants to study the electronic medical record, including an AMA Practice Transformation Initiative grant. They work closely with Dr. Christine Sinsky, who many of you know as a leader in studying joy of medicine and burnout. And, to just show you how incredibly relevant their work is, I just want to mention 3 articles that they're going to be talking about. And I think, the first article is an article that Dr. Arndt did in 2017 before they started working together, which really is a keystone paper in this area. And it was called Tethered to the Electronic Medical Record, Primary Care Physician Workload Assessment Using the EHR Event Log Data and Time Motions Observations. And that was in the Annals of Family Medicine. Two together, collaborative research papers most recently are the effect of remote scribes on primary care physician wellness, EHR satisfaction, and EHR use. It really hot off the press and incredibly important for us. In the Journal of General Internal Medicine in December of 2022 was published Gender Differences in Primary Care, Physicians, EHR Use Over Time, and Observational Study of Critical Importance. I would say that Brian and Mark have been leaders in primary care at UW Health. They sit on two really critically important committees, the Primary Care Comp Governance Committee and the Primary Care Panel Management Work Group, where they work collaboratively. This is an incredible example of cross-departmental collaboration, innovation, and people who are just driven to make our life better. And with that, I would like to introduce Dr. Micek and Dr. Arndt.
Thanks so much, Betsy. This slide, thanks for those disclaimers and disclosures for the committee that brought us here today. When Heidi first came to UW, I was like, what are we going to call our meetings together when we get together and talk about workload? And we talked about the workload beast. When I present, I tend to invoke emotion, good or bad. And this is my emotion that I'm showing here about how I sometimes feel in this workload space that we work in. Betsy alluded to Mark and I wanted to call out Adam Rule from the Information School at UW-Madison, so cross-campus collaboration as well, and Jeff in our Department of Family Medicine, and Christy Schaefer before she departed UW Health. As Betsy alluded to, we have received funding from the AMA, $300,000 over these 4 grants, most recently in 2022, but dating back to 2019. Today, our objectives will be to define workload and explore how the EHR contributes to burnout. It's important to know that EHR isn't the only thing, right? So let's clarify that right off the bat. Distinguishing different methods to measure EHR workload and examining factors related to EHR use, including trends over time, including gender differences. I want to make sure you know that at the end of today, you'll have an opportunity to provide asynchronously electronic feedback through a QR code that'll be open from now until Monday at noon. So I want you to be paying attention and thinking about things that prompt you today. I don't want to hear, Mark doesn't want to hear about what's wrong. We want to hear about what do you think could be done as solutions as it relates to it. So hopefully you'll have some ideas after we talk more today. So I've been thinking about workload a lot, dating back to the 90s in my work as an engineer. And the NASA TLX as a task load assessment is one thing I want to make sure everybody's aware of. This is often what's referenced in literature. And as you can see, it's dating back to the 80s where this is really developed. And it's important to think about the categories that are called out here: mental, physical, temporal, performance, effort, and frustration. In the frustration, for example, when you're doing FMLA paperwork and donning and doffing, PPE, et cetera, that leads to workload and that leads to stress. And then sometimes the EHR is held guilty by association. So I just want to make sure we call that out today. And although a big part of the dialogue today focuses on the EHR, again, we've got family responsibilities, we've got time pressures, we've got the sense that sometimes we can't control the pace. Sometimes there's chaotic policy things that led to immediate release of test results in the EHR, and you're getting, MyChart results or MyChart communications before you've even seen results. Those are time pressures and chaos that you experience. I created this again to invoke some emotion, but to clarify that there's a lot to our stress that we experience. And that's staff shortages, that's med shortages, that's access concerns, that's FMLA, that's COVID questions by the millions, that's the hierarchical condition category, the HCC, that's the peer-to-peer, call me within a 15-minute window and tell me why I should authorize that MRI for your patient that very clearly needs to be done. That adds to our stress, and let's not lose sight of all those factors outside of just the EHR. But in our academic work, let's not also forget that we are mentors, we are teachers, we are researchers, we are clinicians, we are inpatientists, we are the multi-pluripotent capable stem cells at an academic organization that do a lot, and we're asked to do a lot. And sometimes that leads to joy and satisfaction. Other times it's just overflowing. So we're going to talk about this in more detail today in terms of Arndt and Micek reports, but I just want to clarify here and show that even though I start at 4 a.m. on top and I finish at 8 p.m. most days, and Mark generally starts at 7 on the bottom and finishes by 10 p.m. at most days, data like this don't tell the whole story. It doesn't say whether or not I have the opportunity to work out midday, or whether or not I'm able to get to my girls' dance at night. They tell some of that story, and you can see some of that pattern, but just because I start at 4 and end at 8 doesn't mean that I'm burned out and that things are terrible for me. I actually have a lot of professional satisfaction, and this is just one way to show that time of work isn't necessarily associated with how satisfied or not you might be. It's also important to just think about consequences. Today is not about burnout, by the way, but it's a part of what we're talking about. And since we just did that survey, remember that there's consequences on the physician, there's also consequences on the patient, and there's consequences on efficiency of organization, productivity of organization, et cetera, in that bottom healthcare system part of the wedge. I'm not going to focus on these right now, but there's a couple key references in the bottom left I'd like you to look at that are, very recent from 2022 that really talk a lot more about this in relevant ways. I think here, some of the biggest stressors associated with the EHR actually are about insufficient time for documentation and in-basket workload and work volume. And so we're going to get into that in a little bit more detail. I wanted to highlight, though, one of the great papers that Mark did with the group from GIM here. And it did definitely show this association between burnout and your time in clinic, as well as then Julia Adler-Milstein, who's one of our research colleagues out west, who said, in addition, the work that you do outside of scheduled work hours definitely relates to the stress as it's measured by burnout. This, I think, is key. And I'm looking at Heidi in the audience, and I know Mariah has been in conversations with us, Corey Geisler and others. UW Health is listening. UW Health is taking this incredibly seriously. UW Health is making a difference. UW Health is leading the way. We are remarkable in the way that we deliver patient care, but we're remarkable in the way that the world actually is starting to see us as a leader in exploring what can be done about the stress that we experience. I want to shift gears now and just talk a little bit about science, and then in about 5 minutes, I'm going to hand it over to Mark to give you what you really want to hear about, which is the data at UW Health. So, going back almost 15 years ago, Mark Linzer and colleagues started asking folks to self-report EHR use. They're highly labor-intensive efforts. They're subject to reporting bias. And self-report studies like this typically ask the respondent to estimate their time spent or provide the subjective feelings of the time spent. And then a few years later, I guess 7 years later, Krasinski, as Betsy alluded to, who's the vice president of professional satisfaction at the AMA, who Mark and I interact with just about on a weekly basis, she put this together, which combined then self-report with direct observation. And it's important to note here that this was primary care as well as specialty, including cardiology and orthopedics. And in that work, they found that an hour of patient care was associated with 2 hours of EHR time and desk work. And then that same time, actually it started in 2015 and the paper came out in 2017, I was asking the question, how come back-end EHR data that measures the footprints in the sand of us can't tell stories? And let's see if they can tell stories. And that's what Tethered to the EHR was about. And of the 142 family medicine physicians that were in this group, we were spending roughly 6 hours of the workday interacting with the EHR. And at that time, again, data from 2016, so 7 years ago, about a quarter of the time that we were working in the EHR was in the in-basket. Very simply, again, in that engineering space that I came from, this is an industrial engineering tactic of direct observation. We designed a very simple iPad tool on the Work Study Plus app that basically was just the student who was in direct observation marked times of transition when the physician they were observing was doing different things. We could then correlate through direct observation in the back-end EHR data. When we couldn't tell what was going on in the EHR, here's what we saw in person. Let's see if we can untether and find out what's going on in the back-end EHR. So as Betsy mentioned, this was a very early paper that led to a lot of workload data study with EHR event logs. Then most recently here in 2019, this is an interesting thing where it correlated self-report versus an EHR vendor metric from Cerner, not Epic, but from Cerner. And basically here, the provider's self-report of their time in the EHR was about 2 to 3x what the clock measure evaluated in this paper. And so the disagreement between this clinician reported and vendor metric reported is troubling because there's disagreement here, right? What's right, what's wrong, how best to do it, that's what we're trying to figure out. And that's part of the holy grail in this space. But we need metrics, bottom line, that are provided by the EHR vendors that accurately reflect both the time and how we're interacting with the EHR. And so although we don't have perfect EHR use metrics to accurately reflect what each of us feel is the reality of our clinical work days, it is clear that EHR event log data has really great promise to continue to evolve. And research teams like ours define metrics in their own shops, and then those require a lot of analyst time and are difficult to bring scale to those things at an organization level, multi-department level, et cetera. So vendor provided metrics then have this ability to evolve in response to the EHR research team work that we're doing. And some of those vendor provided metrics that have developed as a consequence of some of this work would be things like Epic's total time in the EHR, time in clinical activities such as notes, orders, in-basket time, and chart review. And then there are several metrics that are evolving, including time on scheduled days, time on unscheduled days, pajama time, et cetera. And it's still challenging, unfortunately, to make direct comparisons between EHR vendors who have these different metrics, and the definitions change frequently over time. So I'm going to just pick on one element from this slide that's got three metrics called out, and that is time outside of scheduled hours. You might think that is simply the time in the EHR spent entirely outside of my template starts here and my template ends there. That's what it seems that it would be. However, Epic applies this 30-minute buffer before the first and after the last appointments that are scheduled with patients. So anytime that you work in the EHR during those buffer periods wouldn't be counted as time outside of scheduled hours. It's again, just when you know the nuance of the metric, it somewhat reflects that maybe that's not the reality of what we would want that TOSH metric to represent. So this is kind of the geeky part of today for me before I transition to Mark here shortly. But here I show that TOSH metric, how it can be misleading for two different clinicians, two different schedules, each have 6 4-hour patient care sessions as shown here in blue. Clinician 1 schedule includes 10 30-minute of these buffer times in yellow. And then these 300 minutes or 5 hours of buffer time would be excluded from TOSH's or Epic's TOSH metric. In clinician 2's schedule here, there are 6 of these 30-minute yellow buffer units, which therefore equate to 180 minutes. 300 minutes versus 180 minutes, that's a difference of 120 minutes where somebody might be working in those same timeframes and demonstrate that, gee, organizationally, that person who's working 120 minutes more needs some intervention. We need to fix them. We need to shape them up. But really, it's partly because of the misleading nature of how that metric is developed, as well as the consequence of how we shape our days differently when we see patients, whether it's on a full day, whether it's in half days, whether it's on single days of the week with days in between without, et cetera. And I'm excited to say that come May, that'll be in the annals. So look for that one too. So both Adam Rule and I were part of this paper with Krasinski back a couple years ago, and that was to challenge the vendor community and the research community to come up with standardized metrics that we could all be held accountable to across organizations, across vendors, across divisions, across departments. And in that, we proposed denominators in the per 8 hours denominator, such that it might be easier for me to think about things as a full day of clinic or a half day of clinic. How much time documenting did I do per 8 hours of clinic? I can think about that versus at the per week or the per month level. This is important. The use of these vendor-defined metrics, as well as the investigator measures, has increased almost logarithmically in the last few years. I was in the space probably in 2014, and you can see what was going on at that time with maybe 3 or 4 articles, and now here roughly 60 in 2021, and a lot more in 2022 that utilize these metrics as part of what they present. So it's really important to say, when authors are making conclusions in papers, do they actually lead to misleading conclusions to the reader because of the nuance, or are they actually clinically relevant to the things that we do each and every day? This also, I used to use this as a slide to complain about my lack of interaction with Epic. And now I will say, I'm the medical director at the Verona Clinic, a half-mile away from Epic, and it's a beautiful opportunity. And we do routinely interact with our EHR teams here at UW, our analysts, our research teams. We interact on a regular basis, and we are co-creating metrics together. We have pros and cons that we shoot off of each other to say why this works, why this doesn't work. And so I think that's really important for you to see. This is not a complaint that we're not working well with the vendors. We're in the sandbox playing together, exploring together, researching together, and doing really great work together. I appreciate Heidi and others being a big part of that. I'm going to transition here to Mark to actually open up the black box of some of our own local data here, and he'll talk in a lot more detail of some of these trends.
Figuring out the technology. Thank you. So thanks, Brian, for that initial part of the talk. Betsy, thanks for the introduction. And I just want to mention also that there's a lot of people in the room that I work together with, super excited about. See, Deepak joined us as well, Heidi. I feel very lucky to be part of an institution that really is engaged with this work in many ways. Brian and I are doing the research aspects, but there's definitely our primary care leadership has been incredibly supportive and interested. Department of Medicine leadership also. Informatics has been incredibly knowledgeable and really engaged and participatory in this as well. So I kind of see that this work really fits into a broader whole to really help us better understand how we work in the EHR and improve that over time. So I'm going to transition now to talk about 2 specific areas in which we've done a lot of work with the EHR to further examine it that helps illuminate various aspects of our work lives. One of those will be in how our EHR use has trended over time, and more specifically, like how it has changed pre-COVID 2019 into the after-COVID realm. And then the second thing would be about examining further the gaps in EHR use that we've noticed between female physicians and male physicians. So the first will be around how the EHR use has trended over time. So first, if we can all think about back to 2019, pre-COVID, it's hard to do. But we knew that even along that time with signal data that Brian just mentioned was starting to come out and being used to help examine how we navigate the EHR or just EHR vendor-derived measures. It was right around this time then that people looked back and they started to say, well, how were we engaged with the EHR? So this paper comes from AJ Holmgren, comes from looking at data from January to August 2019. This kind of set the stage as we look at the future. And what it showed here is that US physicians are incredibly more engaged and time consuming with the EHR than other countries are. Maybe that doesn't come as a surprise. Incidentally, this is a study with 348 health systems in the US, 23 outside the US. They all used Epic. So you can't blame the EHR system for this. It's all just the ways different people navigate a very similar infrastructure of health records. But this paper showed that the total time in terms of total EHR use was greater for US physicians, time in notes was greater, time in orders was greater, time in the in-basket was greater. And indeed, we got more messages per day compared to our non-US physician colleagues in other places. It kind of mimics, I think, Heidi, presented on notes, that our notes in the US also are very much longer than notes in non-US settings. And so there's many reasons why people have hypothesized this is the case. A lot of it maybe boils down to the billing and coding and just we work in a different system where documentation requirements have to support certain things that they may not in other countries. I'm sure there's other reasons too, but that's been identified as one of the major ones. And then now looking at how has EHR use changed over time. Before I'm going to get to our UW data, I'm going to present two studies that looked at how EHR use changed in the early phase of COVID, if you will. So looking back at 2019 and then examining through a shorter period of time from, we say that COVID sort of disrupted our health system around March 2020. So one study from AJ Holmgren again looked until January 2021. And then another from Badishi Nash that was published in JAMA looked until May 2021. So maybe about a year out from COVID. And I'm going to present the data here in the table that comes from those 519 physicians at Yale that was produced by Dr. Nath. But that really illustrates the findings on both papers, is that mainly time has increased since COVID has begun and primarily driven by inbox things and kind of virtual and asynchronous care. And so this table shows what they're looking here is on the left column is various ways to measure our EHR engagement. And it is the categories here that I've included is total messages, patient originated messages, patient medical advice messages, which is code for a MyChart message, and then patient calls, and then finally time in the inbox. And how this has changed here for primary care, medical subspecialties, and surgical subspecialties. And I'm just going to call out the medical advice, the MyChart, as an example that illustrates how our work has changed. If you notice in primary care, it increased from 1.8 messages per day was the metric they used to 3.9. So it was over 100% increase in MyChart messages for primary care physicians. In medical specialties, again, over 100% increase, 107% increase. And in the surgical specialties, it was over 200% increase. Although just pointing out that they started at a much lower level. So it increased from 0.4 to 1.1. So they almost got up to where primary care was maybe in the pre-COVID level. And then concurrent with that, not surprisingly, the time in the in-basket also increased. Now, I'll talk a little bit later. Time in the inbox is not very perfectly measured, but probably if we followed over time, we can get a sense of how it changes. And time in the inbox increased 15% amongst primary care physicians, 16% amongst medical specialties, and 46% amongst the surgical specialties. But again, they were starting at a much lower baseline at 7.6 minutes per day versus 21.7 in primary care and 13.4 in medical specialties. So that kind of sets the stage. What we then try to do with our UW Health data is look further into the future and say, okay, now we're 2 years, actually almost 3 years into the COVID pandemic. How has our work continued to change? And we know that it changed for sure in that first year. Has it continued to change or has it stabilized off? And so we looked at this with 160 PCPs, and we included physicians in family medicine, general internal medicine, and pediatrics. And we looked at 3 years total of data from April 2019 for 1 year, which defines our pre-pandemic phase. And then April 2020 to March 2021 is year 1 post-pandemic. And then April 2021 to March 2020 is our year 3. And so what we did is we tried to compare how our work has changed pre-COVID into year 1 and then year 2 over time. And we looked at EHR time and messages, and we always normalize, as Brian had pointed out, per 8 scheduled hours of clinic. And it kind of gives us an anchor, not an FTE, but in hours of clinic, which adjusts for when physicians are in clinic working, adjusts a little bit for vacation and whatnot, where they wouldn't be in clinic, but FTE would maybe say they would be. So we always adjust for 8 scheduled hours in our research endeavors. And then we looked at 5 high intensity in-basket messages, which is while we get a lot of different message types, there's 5 that we felt we really spent a lot of time on. And that's what we focused on in our research: patient calls, prescription authorizations, results, MyCharts, and e-consults. And we recognize our medical subspecialty colleagues are very involved in e-consults as well. And thank you for that. We really appreciate that in primary care. And so we looked again then at how things have trended from pre-COVID to year 1 to year 2. And then these were our findings. And I'm going to first present the data for messages and then the data for time. So one is we found that the messages increased over time, and not only from year 1 to year 2, but also from year 2 to year 3. So this graph shows what those actual means are in terms of these high intensity or labor intensity messages and different types of messages that we received. And then what the mean was in year 1, year 2, year 3. And then we created models to compare year 1, which again is the pre-COVID, to year 2 to year 3, and year 1 to year 3. And I know there's a lot of data here, but suffice it to say that there was an overall increase in messages, and that's this first line here. So it increased from year 1 to year 3 by 6.4 messages per 8 scheduled hours. And that was very significant. And that includes both increases in year 1 to 2 and 2 to 3. But it was driven primarily by my charts. And in my charts, the means increased from 7.4 overall to 11.9 overall for about additional 4 to 5 messages per 8 scheduled hours more in comparing year 1 and year 3. And we saw that increased both from year 1 to 2 and year 2 to 3. So not only has it been increasing initially, but it's increasing even more. And we're probably going to continue this work and see what happens in the future. This now moves to EHR time. So how has our time in the EHR changed? And now on the left-sided column are various ways that we measure EHR time. Brian mentioned some of these already. EHR 8 is the total amount of time we spend in the EHR. Notes is how much time we spend in notes. Inbox, orders, and WOW is work outside of work. Which is, Brian mentioned a little bit of the limitations around that, but it's trying to get at how much time we spend after hours. And we noticed that for every of the time categories in primary care physicians for these 160, it increased over time. And it increased from year 1 to 2 in most of them, interestingly not notes, but then increased in year 2 to year 3. And then looking at year 1 to year 3, which is the column highlighted here, a lot of additional time over that period. And I just want to call out our total EHR time then increased almost 30 minutes per 8 scheduled hours over this course from pre to post pandemic. And then we believe that it is primarily driven again by the inbox. So I'll point out here that the inbox increase was 18.3 minutes over increase over time. But this is where I'll mention that inbox time is an underestimate because it only counts the amount of time you're actually in the inbox screen, but it doesn't account for all the time once you launch off out of that screen that becomes delegated to other categories. So we've done some work that estimates that that's probably multiplied by a factor of 3 or 4 to find out how much time you're actually doing the asynchronous inbox. And so if you multiply this by 3 or 4, you'll probably over account for the amount of total time that we observe change. That might be in part because during this time also our visits reduced a little bit. Certainly right around COVID they reduced, and then by the time we did this study, they hadn't fully gotten back to where they had been. So we probably were doing a little bit of less work on visit EHR work, but more work on the inbox and overall more work. And so why is this happening? You probably are all turning in your head to figure out why it's happening. Maybe you're kind of feeling that it has happening. There's lots of hypotheses. I don't know if there's any right answer or clear answer for this, but certainly a lot of things changed with the COVID pandemic. We and our patients became a lot more used to virtual and asynchronous care. We initially said people couldn't come into clinics, so we had to do things virtually and over MyChart and over telemedicine, which is a new thing for us. And then we and our patients probably started to recognize that a lot of things could be done outside of the clinic. They didn't have to come in for visits, and they got that expectation, and they started to send us messages, and we were responsive, and everyone kind of gets used to that system. I'll also mention that there's no charge. If you do your care over MyChart, there's no charge right now for MyChart messages. I'll point out that there are some institutions that are changing that, but so it's a way to get care conveniently. And then I would say from our end, I think it also became convenient. We could manage things without having patients come in. And we do have access issues, as many other services do as well. And so it's a way to try to manage things outside of the typical having people come in. And then there are other things that we wanted to point out. I think, again, Brian already mentioned this, there's certain policy changes that happened in the interim that might have also contributed to our increased in-basket work. One of those was the 21st Century Cares Act implementation of these immediate results releases to patients, which other studies have found that increases messaging to clinicians because the patients get them before we get them. And so they'll often start asking questions before we can get to it. And so what can be done? Again, I don't know that there's any known silver bullet. I think we're going to ask for, thinking about this from you all and suggestions at the end of the talk and giving us feedback. But certainly, many things have been hypothesized to potentially help with this. Increased staffing would probably help, particularly on the days when the messages are in higher volume. Our data also indicates that most of our messages come to us on Mondays and Tuesdays, and then they kind of taper off through the week. So maybe giving additional staffing for those times to allow the responses to occur in more of an even workflow. Certainly redesigning inbox workflows might be helpful, increasing teamwork and maybe having teams respond and resolve messages, either themselves and then allowing less clinician involvement with it, or moving them to visits if they're complex issues, although that again assumes a lot of visit availability. We certainly have some, but that's a scarce resource sometimes as well. And then that kind of change might help normalize everyone's expectations for what asynchronous care is. We can also consider adjusting templates, putting more blocks during the day to allow these messages to be, gotten to and accounted for before the end of the day. Reduce visit density requirements. We in GIM have a 2.0 visits per hour. Family medicine is 2.2. So, the more visit intensive work we do, the less time we'll have for doing the inbox. That has been the main source of the increase. And then we could charge patients for MyChart messages. That has been done in other systems. AJ Holmgren, I feel like I'm mentioning his name a lot. He does a lot of publishing in this realm. He looked at UCSF when they implemented charges for MyCharts and found that it did indeed reduce the number of messages. As you can imagine, Cleveland Clinic has adopted this. I understand that even health systems within Madison have adopted it. And I know our UW Health leadership is also thinking about it as well, but recognizing there's equity issues and other things to think about before really just implementing this. And in primary care, we also think about our panel sizes. We have a lot of clinicians who are over impaneled. And of course, when you have more patients than you're designed to have, that will result in more work overall and certainly more inbox work as well. So just really trying to figure out what is the right panel size and how to make sure we kind of stick to those panel sizes could be another solution. And there would be others, and maybe you all are starting to think of some, and we'd certainly be happy to hear about those. So then I'm going to turn to the gender gap, which is another area that EHR work has illuminated, if you will, over the last couple of years. First, going to give a couple of example studies that got published before we looked at the work that we did here at UW. So there had been two main studies that had shown that female physicians spend more time in the EHR than male physicians. One of them was at Yale, and the other one was at Brigham and Women's. The Yale study was mixed specialties, so all specialties, including 318 physicians, and they showed that female physicians spent more time, total time in the EHR, more time in notes, more time work after work, again, is the wow. And then the primary care paper showed again that there was also more total EHR time, more inbox time, more notes, and this is amongst primary care physicians. And this is the graph that's depicted here. So if you look at this is the comparative between female and male physicians and their EHR time. And so for total EHR time 8, which is the EHR time spent per 8 scheduled hours, females had a little over 40 extra minutes per 8 scheduled hours in total EHR time, and in notes over 30 minutes in notes. So a lot of that was potentially attributable to notes. And then some of that also occurred outside of normal work hours. They also noted in that study that female physicians got more patient messages and more staff messages. So they were kind of pinged more frequently. So that was one of their ways that they could account for what this difference might be driven by. So with this information, we looked at the gender gap at UW and UW primary care. With those same 160 physicians that included 108 female and 52 male physicians. And then our interest was to see if there was a gender gap at UW in primary care, and then how that also has been trending over time. whether that's been narrowing or whether that's been getting bigger. And we looked at the 3 years, the same 3 years that I presented in the prior study. And then we looked at EHR messages as well as time. And then we adjusted the models for specialty, duration of employment, panel size. We try to get, the amount of additional time, even adjusting for panel size and number of messages. And so what we found was first just kind of stepping back and comparing, this is like our table 1, looking at how do the males and female physicians in our departments differ. And particularly, there were not a lot of differences between duration of employment, but there were some things to point out in terms of the workloads and the panel sizes that they had. Number 1 is that females had a slightly lower clinical FTE compared to males. And concurrent with that, they also had slightly lower panel sizes compared to males, likely because they had lower FTE, and we peg panel size to FTE. The monthly visits they did was also lower, again, probably because of the pegging to FTE. And then if we looked at visits per 8 scheduled hours, so that has to do with the density of visits, that became non-significant, maybe females a little bit more, but non-significantly. And then if you looked at the number of messages per 8 scheduled hours, there's actually no difference between females and males. So a little bit different from what was found in that other primary care study. And that was not significant at all. And then in terms of our EHR time in females versus males, and this is almost hard to say, for 8 scheduled hours, the females in our system were spending 1.5 hours more time in the EHR than their male counterparts. They spent a little over an hour extra in the after hours period, and almost an hour more in notes. And inbox was also significantly more. Again, that number looks low maybe as 0.2 hours per 8 scheduled hours, but we multiply by 3 or 4, I think, to think about how much time in the inbox that difference might actually represent. And then not only did we know that they have a higher amount of EHR time, but we also observed that that was increasing over time. And so this table here again presents those on the left side here, the EHR metrics. And it looks at what year 1 is, year 2 is, and year 3 is. And then the red highlighted column is the comparison and the model increase per year between females and males. And this is published in JGIM last year. And then we found that the average increase for the total EHR use was about 8.3 minutes increase. A lot of that was in the in-basket, 3.3 minutes, again, with that multiplier factor. No change in orders, incidentally. So they were, and no change. There's a dynamic about orders, but at least that seemed to be similar. And then a lot of that work again was spent in outside of work, in after hours work outside of work. So what is causing the gender gap? There's been lots of discussion about that. And again, we'd hope and think that you probably would have a lot of ideas as well. It's been hypothesized that maybe it's because of more inbox messages. We did not find that with our data, and I think that has to do with our panel weighting system that I'll get to in a little bit, that I think tries to mitigate some of the differences in messages. But we did not see any differences for messages. But other systems that maybe don't weight like we do, that might definitely be at play. Maybe we noticed there wasn't an increase in the quantity of MyChart messages, but there was definitely more inbox time. Maybe there's something about the way that messages get handled that's differently, more writing or different questions. We actually don't know that, and there's some new methods to try to look at, character accounts in MyCharts that are received and MyCharts that are sent in. Maybe they're sent to female physicians with less work done before they get sent, less triaging, less information. We do know that there's a statistic about the percentage of messages that get routed to us. All messages come in and are usually triaged by someone, a nurse or an MA, and then they get routed to the physicians. Incidentally, our data is only the routed ones that we have gotten. But we know, at least in our system, that the percentage that get routed to physicians is not different than the percentage that get routed to males. But there might be something different with that triage process. There might be different panel populations that female physicians and male physicians take care of. We definitely know that to be the case with gender. That graph down at below represents in GIM and DFM And this actually is not really true in peds because people probably don't self-select if they're infants and young adults so much based on physician gender. But we do find that for adults in GIM and family medicine, they do select. And so what this graph shows is in the yellow are the female physicians, the proportion of female patients on their panel. And then the blue is the proportion of female patients on male physician panels. And if you notice, there's little overlap, such that females have higher proportions of female patients and males have lower. In fact, a lot of the overlap might be due to the kids in family medicine. And if we looked at the graph in GIM, there would be no overlap. And so there might be some difference that is just resulting from this difference. And there might be other differences in the panels that choose female physicians versus male physicians that might generate more EHR time. And then I'll just point out the notes. The notes was something that came out specifically as a difference between male and female physicians. I think more work needs to be done on that. Note length, note time, pre-visit preparations, things like that, that all build into our notes might really have differences. And, developing best practices. How much time should we be spending on our notes? I don't know that anyone really knows that answer, but certainly with these discrepancies, it does identify that there's something that might not be right with the current system. And what can be done about it? We'll ask you for your thoughts as well. But one is probably any effort to mitigate the in-basket burden will help female physicians, particularly because of the amount of time that they seem to spend more in that task. We could consider adjusting panel weighting to account for what drives that work a little bit better. And we do weight, I was going to mention, we do weight on gender. We do know that our panel weighting group knows that female patients generate more visits and messages. And so you have a weighting system that looks at past activity and tries to predict future activity. And so we weight female patients higher than male patients so that's why I think that it evens out the in-basket, because female physicians actually have lower numbers of patients, even though their weighted patient population is the same. But maybe there's other ways we could be doing this weighting to better account for those differences that are occurring. And other things that I'm listing here can be really for any physician: health link optimization, documentation support, scribes, but may particularly be underutilized for female physicians that might be struggling. So what's next? This again is an acknowledgement that over the last several of years since I've been involved in this arena, there have been a lot of things that have been done and a lot of thinking that has been done by a lot of groups here, ourselves, but also informatics groups, our primary care, the leadership groups, Department of Medicine groups, our wellness groups, like all very, very interested and focused on this. And I'll point out there have been a lot of things that have happened that have been good over this period of time. And then also some that have happened that maybe have been a detriment to our EHR workload. So I'm not going to go through all of these in a lot of detail, but the single sign-on I thought was definitely an improvement to the way we used to do things. Typing in, now we have our 13-character password, so when we're not at work, we've got a little bit more time for that. Secure chat emojis. Dave Kunzman, who's our acting chief medical informatics officer, mentioned that in secure chat we're going to be starting to use emojis. And I originally raised my eyebrows and said, well, I don't know what the point of that is. But it turns out if you give a thumbs up response in your secure chat, it doesn't ping the person that you've responded. And to me, that actually would be a nice benefit, because it's sometimes when you're with your patient, you get pinged, and it's really just a thank you. So it will allow you to obviously see that, but it won't ping you. And incidentally, there have been projects at other health systems to try to eliminate that thanks, because it really, again, it's just it creates your attention to be directed in various places. Standardizing best practices, I think, is a very important part of trying to solve this. Figuring out what is the best way to do this with some customization involved, but really trying to figure out this is the way that we really try to promote doing that. I think the APSO note that was spearheaded by Peter Kleinschmidt and the informatics group is a great example of that, that both helps streamline, reduce note bloat, documentation, and then also when you go back to that note, assessment and plan is right at the top. So that has been super helpful. I'll mention our organization has tons of HealthLink training opportunities and modal training opportunities. We do ease of practice tips in a variety of forms. We've been doing that in GIM since 2017. Department of Medicine now does that at the town hall meetings. Family medicine has done that as well. I know that pediatrics, internal medicine, the primary care groups are also interested in reaching out to physicians. Megan Newman has done this in pediatrics, trying to meet with them and optimize certain processes, and that's been received very positively too. And then we have remote scribes. I'll present a little bit of data on that. Definitely seem to improve EHR time and wellness, but we noticed that over time, there's been turnover amongst the scribes that has created some complications and a little bit of less satisfaction with that. And then the billing and coding changes, I think in general have been a positive for us, reducing the amount of time we spend on the history, for example, and really put the most important parts of our note assessment. But then there's been some steps backward that I'll mention, multi-factor authentication. I think our patients are also burdened with that as well. Controlled medication prescriptions have become a lot more lengthy. The hierarchical condition coding is something that we deal with. I think everyone in medical specialty does as well, but we get pop-ups if we haven't addressed certain things. The immediate results policy that we've already mentioned. Delegation authority, we have that in primary care, so we delegate certain things to nurses and MAs, which has been an extraordinarily help for our workflows. But there are always other things that could be done or troubleshot in those processes as well. And then I'll just mention the remote scribes project that we did. Remote scribes are available, I think, for all ambulatory clinicians at UW Health. What we did is when this got implemented in primary care, we just did an evaluation and a comparison of this data will represent 37 PCPs that got the remote scribes. They were self-selected. This was not randomized. And then we compared them to 68 PCPs that did not get scribes. And the scribes, again, are on a phone in your pocket, listening in, doing documentation work for you. And we noticed that it helped impressively, I think, with burnout and also with reducing EHR time. I'll just mention here this mini Z burnout item, which is that single item question that asks people to identify on a 5-point scale how burnt out they are in a self-perceived way. That went down for the people in the scribe group and actually went up for the people outside the scribe group. So it ended up with an 85% odds reduction improvement for people in the scribe group. And then it also reduced our EHR times with scribes by over an hour of a day total in the EHR was reduced amongst the scribe group compared to the non-scribe group. And then a lot of that, almost all of it, was reduction in notes. And so I'm just going to leave with this image and then turn it over to Brian. As we've been talking about EHR times and generally presenting means, I do want to make it clear that even at our institution, there is a wide range of how clinicians manage their EHR, manage what they do, where they click, manage how they interact with their teams. So this is a graph of people's EHR 8, so the amount of EHR time they spend per 8 scheduled hours in GIM, DFM, and pediatrics. And I left off some of the outliers, but I think this gives a really good demonstration of not everyone works the same. And in GIM, the average is higher than in the other two. Family medicine is shortly behind. And this is about 6 2/3 hours of time. Family medicine is here, and pediatrics spend a lot less time in the EHR. But even within our departments, there's a wide spectrum. And so I don't know that our future frontiers would be to figure out, well, how much time should we be spending? What is the amount of time we should be spending on our notes? We also have quality work to do, right? To look at our panel and do panel management outside of asynchronous care. How much time does it take to do those things? And I think we're still learning that. And we're also learning, what is it that makes people different in this realm? Like, why is someone spending 8 hours versus someone else is spending, 4? That's a big difference. And so we have some projects where we, ask people to participate in a study where we interview them and watch them to try to glean some of the differences. And I appreciate for those that have been able to do that for us in the past, and we'll probably be continuing to reach out to others to be involved with those types of studies with us. And I think it really helps us better understand our work and how to make it better.
We're going to finish up here so that we've got a couple minutes for questions. The conclusions: EHR workload contributes to physician burnout, but remember, it's not the only thing. Time in the EHR can be measured with vendor supplied metrics, but there's limitations. We're working on those. Thirdly, EHR use is increasing over time, and particularly in basket, and there's clear differences between male and female physicians, and there are strategies to make this work better. So I want to leave you with this Padlet. So that's a QR code that'll give you an opportunity to provide us feedback. And these are just a couple prompts. You know, what could we do about this message volume or the time spent? What could we do about the gender gap? I'm going to sneak over for a second and then I'll leave it on this, but the Padlet will show up like this. It'll be available now until Monday at noon, and it'll prompt you with that same thing up on top. You just double click into the green space. Number 2, you say subject. So try to be positive and productive here. This is not telling us what's wrong. It's about solutions, ideas, but try to guide us with your subject. Like, this is about documentation, or this is about gender, or this is about MyChart messages. Then number 3, you type that in, try to use 2 to 3 sentences, maybe at most. And then number 4, just click publish. And what will show up are these little white paper pads or Padlets on this collection. So please do provide us that feedback. I'll leave you here.
I've got a call out. Fantastic. So a call out and a comment and a question. The call out is, I understand your national reputation, Dr. Arndt, precedes you. Our local historian, Dr. Michael Lucy, texted me that you were quoted in the Atul Agawande New Yorker article about why doctors hate their computers. So there you go. And then just a comment that was kind of an aha moment for me was, you know, using percentage increase, if you compared surgeons and then primary care physicians, is really very not the way to go. You have to start with just the number of messages that each of us get in different specialties and how it really calls out the different kind of work that we do. If you're a proceduralist, if you're someone who practices in a clinic setting. And for one of you, I would want to answer, you asked us the question of how can we rein in the EMR workload? What is the one intervention that one of you would choose to do if you wanted to make the biggest impact? And then we'll go to other questions.
That's not a fair question, Betsy. Yeah, it's about controlling MyChart communications, but through an agreed upon what works for patients, what works for us. We want to be equitable. We want to be available. We want to meet you where you are. We want to not charge you for every contact that you have with us. But what are the guiding principles, and what are the guardrails that we as a clinician community and patient community agree together that this is a public health burden on the health of the physician team and the care team? How can we do that? I think that, to me, is the one thing that needs to happen.
Thank you. Questions? Dr. Schnapp.
So thank you. Great talk, really important subject. Love the work. A comment and then a question. So Mark, you had put the immediate results on as your step backwards. I would posit that's actually a step forward and a good thing, and maybe should be in both categories. So that's more of a comment. My question is, that last slide showing the range of time in EHR is really important. And the question is, can you demonstrate any correlation of time in ER with quality metrics, patient satisfaction, et cetera, to help answer your question?
That's a great question. Number one is, thank you for saying that immediate release. I do think that it has been a positive for patients that get that result, and then sometimes they ask us questions that need to be managed urgently. So I agree, for other reasons it's a step positive. For the EHR stuff, it just can sometimes create extra work, but I thank you for pointing that out. And then the other question was about correlating quality. Yeah, so there has been one study that has looked at quality of care and found that there was a correlation between improved quality with increased EHR time if your FTE was under 0.5. Now, we have done some other work that has looked at, we didn't present today, that has looked at FTE and time in the EHR. And I think it basically shows that your time, like comparing full-time with lower full-time people, it doesn't track like you think that it should. There are certain time categories where where lower FTEs actually spend a higher proportional amount of time in the EHR. And we hypothesize that that's because of inbox work, and then also maybe because of panel management work, that people with lower FTEs have some other time to potentially do that, whereas people with higher FTEs don't. But I would say that is only the one study that I've seen. I don't know, if, Brian, if you wanted to notice others, but one that had mentioned that there was a positive relationship, at least if your FTE was low. Maybe because, again, the higher FTEs don't have a lot of additional time to put in for that kind of work.
Another question, then we'll go to one online, and then I know people will have to sign off and leave, but we might continue the questions.
Thanks. That was super interesting. Especially as a hospitalist, I don't get to see a lot of this. So I have a parent who lives overseas, and as he's getting older, he's sending me all his medical records from overseas. And you're right, the notes are just so much shorter, so easy to read. Is there any movement towards that, just making our notes less long, shorter, less long?
I think that too has to do with how do we agree to communicate. Pharyngitis as the history, strep positive as the objective, and amoxicillin as the plan. That probably for me is enough information to know exactly in that case what happened. Now, the patient who's suicidal and has psychotic delusions and things, I need to know more. I'm going to pick up my M-modal and dictate that in the history, and then needs to go to the ER for emergent evaluation or whatever in my assessment. So I think, again, it's about what are our guardrails to work together with, and how do we appreciate needing information dense, knowledge dense, conveying of next steps plans versus we need a whole lot more in certain circumstances. I think for our triage teams, and whether it be access center or it be our RN triage in the clinics, they need contingency plans. And so I've been coaching and guiding and directing in our training to say, spend time in the assessment plan with contingencies so that you don't get the message back such that you told somebody else what could.
So we still have over 100 people online and people here. I'm going to ask an online question from Dr. Mariah Quinn. Amazing grand rounds, amazing to see your work and the workload with gender gap issues. Her question is, I wonder if we are in a place where we can understand the impacts of secure chat. This is very detailed in terms of work interruptions, task switching, etiquette of use, etc.
Yes, we have that. Definitely one of our AMA research partners has taken very deep dives on this and has seen, as Mark alluded to, the number of communications where they respond with thank you versus others, which led to the emoji, thumbs up and things. Yes, we absolutely have that at other institutions who've led that charge. We'll do that locally here as well.
Deepak Gopal, I'm coming back to you. The price is right. You have the good question?
Thanks, Betsy. Mark, Brian, wonderful talk, and thank you for sharing your work. Two quick things or 2 points. Of all those categories that you showed where people spend time, I'm wondering, are there aspects that we could just remove altogether? And I'm thinking about low-hanging fruit of things like orders, where it was almost 18, 19 minutes spent. 21 years ago, when I came here, how we used to do orders was one sheet. You ticked off your labs, you ticked off your CAT scan, you ticked off your colonoscopy request. Effectively, that is a delegation protocol. And I'm just wondering if there are strategies at a level where you can just simply do that, so you're not having to put those extra effort and typing it. And number two, I'm just curious, just even internal data, if those divisions or departments that have medical informaticists, if their workflow efficiency are much better than those that don't. Just curious if you can comment.
Thank you. And then that'll be the last question.
Well, how to answer the last one, that last question about whether or not how, the informatics, I would maybe open it up for, Heidi and others to consider that. In terms of the orders though, I think that is a great area that is ripe for improvement. In our qualitative work, we heard from physicians who had worked in prior times, as I did myself, where you would just say something and it got done.
Just saying.
Now Now, I think a lot of the barriers that we see with that, though, I would get back to this idea of associating orders, like you'd have to include that information in there. You'd have to include, like, if you were going to say a talk order for an antibiotic, the quantity, all that kind of detail. And then maybe even associating also with an antibiotic, well, that's not critical. But I think that's what's led to a lot of the barriers. And then,
But untapped, I'm gonna interrupt you for a second. Mammogram is a great example. Yesterday, I counted coming in here, hoping you might ask that question. I got 3 telephone or my chart questions that I wanted my mammogram. Then the clinical staff have to go and answer the 3 questions that need to be answered for the mammogram. And they're answered, now it comes to me pended for me to sign it. We have delegation authority already for health maintenance that allows for that to be signed. And so that's about how do we execute on already things that exist and say, if the patient opted in for that, now, of course, I value shared decision-making. Laura taught me about that in medical school. Like, I care about that. If somebody wants to have a discussion, should I or shouldn't I get one? But if they want one, I don't want to put a barrier to that. And I'm going to, through delegation, make that happen. So an example, whether that's right or wrong workflow, it's an example of how we could quickly bypass. Heidi, I think, had a reaction.
I could answer the question about the departments with informaticists. We know from our 2020 class survey, we don't yet have the data from the most recent one, that departments and divisions that had a physician informaticist had a higher EHR satisfaction rate than those that did not.
Thank you.
So great. Thank you.